We are deep. So I want to check it. Yeah, I think we are live, and this is the presentation that will carry on. Are you there, Avanya? Hello. Mhm.
Sir, is it visible right now like a slideshow? Can I start?
Yeah, please go ahead.
Good morning, everyone. So today's topic of discussion will be de-resuscitation in ICU. So what is the big deal about de-resuscitating a patient? We have resuscitated the patient and patient's hemodynamic goal is achieved and we are happy, everyone is happy. But why should we think back on de-escalating or de-resuscitating a patient? What is the problem with venous congestion? So as we all know that in critically ill patients, there are multiple factors which can contribute to a fluid overload. The overzealous fluid administration that we are doing by ourselves when patient is coming to us initially. Also other factors, there are multiple reasons for right ventricular failure in a critically ill patients, and also there may be pulmonary hypertension, and also along with renal dysfunction in critically ill patients. All these contributing factors can lead to a significant fluid overload. What happens with the fluid overload? When there is an increased venous volume or there is a reduction in the arteriovenous gradient. So when the gradient is decreased, that may hamper the perfusion, adequate perfusion to the particular organ. Also, along with this, when there is a prolonged elevation of capillary hydrostatic pressure, along with fluid-induced dysfunctional endothelial barrier, that is glycocalyx damage occur, there will be interstitial edema formation, which in these organs, which are encapsulated organs like kidney and brain, it will increase the.
Sorry to interrupt, Lavanya. Are you moving your slides or are you still on the first slide?
My slide is showing venous congestion, sir.
Then it's not moving. We are still on the de-resuscitation
So
title slide.
now with this mode,
Yeah, yeah,
I
yeah.
will continue
Okay.
with this, sir. Sorry
Yes.
for the
Okay.
inconvenience.
Okay. Continue.
Yeah, now the slides are moving, sir. So basically, because of the interstitial edema, there is an increase in the interstitial pressure, and it decreases the organ perfusion further, blood flow further. Also, because of the edema that is present in the tissues or interstitial edema, will lead to impaired tissue oxygenation, because that increases the diffusion distance for the oxygen. So that is why The most common organ that gets a hit
We can't hear you, Lavanya. Lavanya, we can't hear you.
Sir, extremely sorry. It is a good Wi-Fi, but I don't. Very sorry.
Can we restart?
Sorry, sir. So, the pathophysiological effects of fluid overload being main effect on the kidney. The positive fluid balance, it itself contracts its own resolution, means it will lead to a kidney injury that it itself causes further the fluid overload. So, it contracts its own resolution. So there are multiple studies that have been done how a venous congestion and fluid overload are bad to the patient over last 2 decades. Out of which there are some main studies which have showed there is increased mortality in patients who have had fluid overload. So, like in SOAP study, which was done in septic shock patients, there is an increased mortality and acute kidney injury with an increased incidence of acute kidney injury. In the FACT trial, which was done in ARDS patients, when the conservative fluid strategy was followed, it did not show any mortality benefit, but it did show some decrease in the ventilator dependence days and decrease the hospital stay. But it did not translate into mortality benefit. But so multiple studies and pilot studies have also been done whether fluid overload patients have increased mortality. But most of the studies have showed increased mortality or at least the secondary outcome, that is increased morbidity to the patient. So hence we should be very careful in administering the fluids. We all agree that fluids are drugs. So the 4Ds being drug, dose, duration, and de-escalation. How we always, for the antimicrobial stewardship, we always think of what is the correct time, dose, duration. We have to think the same with the fluids also. And always these 4 questions should be in mind: when to start it, when to stop the fluid therapy, when to start deresuscitating or start the fluid removal, and when to stop it. So we should have some clear guidelines about this, or we should start implementing and thinking about these things. The 4 indications, we all know that not only for the resuscitation, we use fluids in ICUs for other purposes like maintenance, replacement sometimes, and also nutrition is ongoing. So, there's some 4 fluid phases is a very important model, conceptual Rose model. I will be discussing in the subsequent slides. So, what is deresuscitation? It is basically removing the fluid actively so that the patient is fluid overloaded. So we have to actively remove. Before doing that, de-escalation, that is restricting the already administered fluids, that is ongoing fluid resuscitation, should be conservative or to be restricted. That is called de-escalation. And de-resuscitation means it is active fluid removal. It is either through drugs or using a ultrafiltration technique. So fluid overload definition, it varies from patient to patient. No proper consensus on the definition, but most accepted definition being when there is a 10% body weight fluid accumulation. It can be given by cumulative fluid balance in liters by the patient's baseline body weight and multiplied by 100. It can give a rough idea about how much fluid is accumulated, how much overload has happened. So it is better to use a word called fluid accumulation than a fluid overload. Fluid accumulation definition being pathologic state of overhydration, which is actually associated with clinical impact and worse outcomes, which is affecting the organs actually. So this again may vary with the multiple factors, that is age, comorbidities, and phase of illness. So whenever there is accumulation of fluid, do we think that intravascularly also there is a hypervolemia? No, intravascularly there can be normovolemic or hypovolemic also. Basically, accumulation describes a continuum. In all the individuals, we cannot keep a specific threshold of this much of liter is accumulated, this much has to be removed. This specific threshold cannot be given. And what is fluid accumulation syndrome? Any percentage of fluid accumulation or overload which has a negative impact on the organ function. That is what is more important to us. It may or may not be associated with global increased permeability syndrome as in the septic shock. So the multiple effects of venous congestion or fluid overload or accumulation on different organs is shown in the picture. So starting with the renal, which takes the hit first. Renal interstitial edema increases, leading to decreased venous pressure and increased interstitial pressure, which leads to low GFR, and it can cause the renal failure and increased uremia. Renal compartment syndrome can occur. And liver-wise, there is increased hepatic congestion and impaired synthetic function of the liver and increased cholestasis and hepatic impairment, and hepatic compartment syndrome can occur. As per gut or gastrointestinal tract, there is increased ascites, gut edema. It can cause ileus. It can increase the intra-abdominal pressure and abdominal perfusion pressure. And because of all these things, the enteral feeding may not be tolerated well, and increased bacterial translocation leading to infections. So all these are the bad effects on the gut. Cardiovascular effects being increased myocardial edema and conduction disturbances, and diastolic dysfunction can happen. So that can lead to decreased cardiac output and myocardial depression. So respiratory wise, we all know that we are mainly worried about this thing also. And there can be increased pulmonary edema, increased effusions, and decreased oxygenation and increased PaCO2. And also extravascular lung water can increase. And this leads to the prolonged difficulty in weaning of the patient, and work of breathing increases. On CNS, there is a development of cerebral edema, increased ICP. So intracranial hypertension can increase and can lead to deleterious effects. On the abdominal wall, there is an increase in the edema, poor wound healing if this is a surgical patient or any wound is there, and leading to a pressure source also, pressure ulcers also can develop. So these are all the deleterious effects of fluid overload or accumulation in the on different organs. So that is why we clearly understand that we have to de-resuscitate a patient, not just to resuscitate the patient and leave. Now, this is the ROSE concept, that is, it is a 4-hit model of shock. So over the time, how the patient's cumulative fluid balance is, the evolution of the fluid balance of the patient has been shown here over the 5 phases. That is, in the resuscitation, optimization, stabilization, evacuation, followed by there is a hypovolemia also if there is a excessive de-resuscitation. So these are the 5 phases. Now, initially, when the patient comes to us, where I'll go to the next slide and show that Rose concept, where initially patient comes, he may be hypovolemic, and we start a life-saving resuscitation phase to rescue the patient. So what we do here is early adequate fluid management. That is, as per surviving sepsis guidelines, it is either 30 ml per kg per hour or a fluid challenge or bolus that is given at 4 ml per kg or 5 to 10 minutes. So we have all extensively discussed regarding these things, what are the hemodynamic goals and what to achieve, and dynamic parameters are better, cardiac output based parameters are better. So the triggers to start IV fluids we kind of already know. Next phase comes is optimization phase, where we are more worried about organ rescue. So here we have to avoid the fluid overload. We have to aim for a neutral fluid balance. So when to stop fluids, again, similar thing, the dynamic parameters, keeping in mind, we can, the triggers to stop fluids. Our main concern for today's topic is stabilization and evacuation phase. So in stabilization phase, you try to support the organ. Homeostasis has to be achieved, where late conservative fluid management, that is, here probably like de-escalation or restricting the already ongoing fluid to achieve a negative fluid balance at least for 2 days in first 1 week after initial insult. This is defined as a late conservative fluid management. Here for de-resuscitation or de-escalation, the triggers to start the fluid are mean arterial pressure. Maybe not all are very sensitive. It's better to use a volumetric parameters than a barometer, the pressure parameters. That is global end diastolic volume index or left ventricular end diastolic area index more than 14, and extravascular lung water of more than 10 to 12 ml per kg of predicted body weight. These are some important triggers to start fluid removal, but there are multiple indicators to tell us that we have to start the fluid removal, out of which now coming up is the VEXUS score, which I will be discussing. Can be done on bedside, and it's simpler. All of us have ultrasound. So it is better to implement this one rather than any of the parameters. I will be discussing that in subsequent slides. When to start the evacuation is a focus on organ recovery, where we have to actively remove, it is resolving the fluid overload with active late goal directed fluid removal and achieving a negative fluid balance. So when to stop the fluid removal is also important, because again, the patient may become hypovolemic by overdoing the de-resuscitation. So when to stop it is again, map of less than 55, abdominal perfusion pressure of less than 45, again PPV, SVV of more than 15%, and mixed venous oxygen saturation of less than 70 to 75%, central venous oxygen saturation of less than 65 to 70%. There are some specific tests that are like indocyanine green test, but I don't think it is readily available to do. So I will be discussing when to start and when to stop in more detail. So when to start de-resuscitating a patient, we got to know that we already know that when it is negatively impacting any percentage of fluid accumulation, when it is negatively impacting the organ function, we have to start. It can include, to summarize, it can be a clinical sign, laboratory parameter, radiological sign, and altered cardiopulmonary function in terms of filling pressures and volumetric preload and low pulse pressure variation, which I have already mentioned. So any of these can be the triggers, but do we have a clear trigger when to start? So as per all these techniques have shown beneficial to assess when to start the fluid removal in previous studies. So they have considered negative passive leg raising test as the indicator to start fluid removal, mainly in the renal patients, renal failure patients. And but it may not be exactly telling us that a really patient is fluid overload just because a negative passive leg raise is there. And as I've already told, extravascular lung water index of more than lung water of more than 10 to 12 ml per kg of predicted body weight will tell us that patient is definitely overloaded. And other techniques like albumin marked isotope dilution technique and bioelectrical impedance analysis, bioelectrical impedance vector analysis. Uh, as per my knowledge, all of these are not available right now with us at least. So what I felt is the most important tool that can be used is VEXUS protocol. That is venous congestion evaluation using ultrasound. So what is VEXUS protocol? So that is to assess how whether the patient is overloaded or not, venous congestion is present or not, and it can as well give the severity of the venous congestion, and not exactly the number, maybe the severity of venous congestion can definitely be told with a routine ultrasound that we are using day in and out with a VEXUS protocol. So we all know how to do IVC by now. We can see the IVC, see the collapsibility, measure it, measure the diameter. So all of these we are very well versed. But is it sufficient? Only IVC assessment, like how we thought, like CVP, some people felt it is a waste thing to use for hemodynamic goal. The same way, the IVC may not necessarily mean that patient is fluid overloaded. And also, it will not give any assessment. It will not quantify the amount of venous congestion in the vital organs like lungs, liver, gut, and kidney. So hence, it is very important to develop a tool which will let us know the early signs of venous congestion. And by limiting the fluid administration, we can avoid end organ damages. So that's why there's this focus point of care ultrasound using VEXUS protocol has come into place, where we when to start it when the patient has patients with septic shock, congestive heart failure, right heart failure, acute renal failure. But is this ultrasound, that is VEXUS protocol, is the only way how we should assess the patient's venous congestion? No, it should be in conjunction with the other things like clinical picture, lab values, and hemodynamic status of the patient. So what all in focus, what all we see? The venous congestion is seen in to be assessed in liver, gut, and kidneys, so that we can predict early signs of end organ damage and change the fluid management strategy. And also, we will get to know the etiologies of venous congestion, like such as causes of right heart failure. Now, in VEXUS protocol, it's a 4-step approach. In the first step that we already discussed, all of us know how to look at IVC and where what other organs can have a overload or venous congestion. One is liver, so look at hepatic veins. Third step is to look at portal veins for the gut venous congestion, and fourth step is to look at renal veins to look at the kidney venous congestion. So the first step I already because of this slide sorter, sir, I'm not able to show the animation and all. So sorry for that. But IVC assessment, we know that sub-xiphoid position, we keep either the echo probe or the curvilinear probe to look for the IVC. And by now we all know how to measure it. And if it is more than 2 centimeters, sir, can you see this slide changing, sir? Because I wanted to show different.
Yeah, slide is changed.
Slide is changing, but is it the full screen, sir? Like a slide show?
It is not full screen.
Sir, because I have made all the images as a animation, sir. So one after the other it comes. So I think I am missing on that. Sorry, sir.
Okay.
Does it, the images, are they changing, sir?
Have you changed it now?
So now I'm seeing hepatic vein Doppler assessment. I'll continue with the.
Continue. Yeah, please continue.
I wanted to show the video, sir. So the second step being hepatic vein assessment. We keep the probe just lateral to the midline, and I want to show the video, sir. I'm just going to the video. So when we keep the probe, we see usually three hepatic veins, that is right, middle, and left hepatic veins. So because of the ease of access, usually we use a middle hepatic vein, it is preferred, but whatever you say, it is okay. Keep the color, it should be blue, and then put a pulse wave Doppler on the hepatic vein. So we see the wave like this, the normal wave like this. So that's the pulse wave Doppler we are putting in the hepatic vein, middle hepatic vein. And that will be seen as. So this is the normal pattern. Going back to the slideshow. So how to interpret this hepatic vein Doppler? Normally, the systolic wave is more than the diastolic wave, on the negative side. So when there is a venous congestion and there's a mild venous congestion or mild hepatic venous abnormality, the systolic wave amplitude will decrease compared to the diastolic. So S is less than D. When there is a severe hepatic vein abnormality, there is a reversal of the waves. That is, S wave reversal happens when there is a severe venous condition as per the hepatic vein Doppler interpretation. Now, next step 3 is to assess the portal vein Doppler. So we are using curvilinear or abdominal probe for all these three veins: hepatic, portal, and renal vein. So by keeping the probe in the mid axillary line on the right side, we get again, sorry, sir, I'm going back to the video. Yeah, this video is showing the portal vein by keeping the probe in the mid axillary line. This is the portal vein. When you put the color, it is seen as a red color, and wherever the bright red is there, you keep the pulse wave Doppler, and you see the wave coming, Doppler coming like this in the normal patient. Going back to the slideshow, the interpretation of this one, the portal vein, normally we have to calculate pulsatility index. That is V max by V minimum by V max, as seen in the picture, V minimum and V max. So if the pulsatility index is less than 30%, the variation should be less normally. But if there is a pulsatility index which is 30 to 49%, is a mild portal vein abnormality. If it is more than 50%, is a severe portal vein abnormality. So the next one, the most tough one, is probably what I felt when I did, is the renal vein Doppler. So it is kept in the posterior axillary line, the similar on the right side, similar like a when we kept in the mid axillary line for the portal vein, this is in the posterior axillary line. And again, going to just one last video. So this is the kidney, and interlobar vessels. It's actually slightly difficult to get it, but wherever you get the maximum color, so put the Doppler there, and the normal wave is seen like this. But this is the arterial, the one above, and below is the venous. What we are worried about is venous. So how to interpret the renal Doppler? So normal intrarenal vein Doppler will be a continuous monophasic flow that we have to see here down, that is venous flow. And if it is a mild abnormality, it is a discontinuous flow where there is a biphasic flow with systolic, both systolic and diastolic phases will be seen. And if it is a severe intrarenal vein abnormality, there is a monophasic flow, but it is discontinuous. There is only diastolic phase. So now we have done all 4 steps. If there is IVC diameter of less than 2, there is no headache. You can just stop the VEXUS protocol there and no need to continue with the further steps. Only when it is more than 2 centimeters, go through all 2, 3, 4 steps. Then how to interpret this? If the IVC less than 2 centimeters in the first step itself, it is called grade 0 VEXUS. There is no congestion. Now, grade 1 mild congestion means IVC more than 2 centimeters is there in all grades, along with any of these 3 things showing a normal or mildly abnormal pattern, one of these. And grade 2 is moderate congestion, where one severely abnormal pattern, that is in all these 3, any severely abnormal along with IVC more than 2. In grade 3, that is severe congestion, more than or equal to 2 severely abnormal patterns. This is how we grade the venous congestion based on VEXUS protocol. So this pocket card is very helpful when we will start or trying to do bedside. This one particular picture will help us go through all the steps. And now that we have seen how to assess, now that we have assessed patient is having fluid overload, what to do to actively remove that fluid. So whatever parameters that are achieved during the stabilization phase, where we are doing a conservative fluid management, late conservative fluid management, they should be maintained during de-resuscitation also. So first step is to either restrict or de-escalation is the first. Then use the active fluid removal in lines of pharmacologic or non-pharmacologic methods. So the drugs that are commonly used are the diuretics, loop diuretics like furosemide, bumetanide, carbonic anhydrase inhibitors like acetazolamide, mineralocorticoid receptors like antagonists like spironolactone, thiazides like indapamide. So is there a role of albumin in de-resuscitation? So there was this PAL approach that they have done previously. So I don't know how much it is followed right now. I think sir will be able to tell me. But so PAL approach said that high PEEP at least equals to intra-abdominal pressure, followed by giving albumin, that is at least 20% of albumin, 2 albumins of such in 24 hours. So that is first day, that is per day. And followed by to maintain albumin levels of at least more than 30 grams per liter. And they also gave so first step, that is high PEEP, they thought that from the interstitial edema, from the organ, it comes to the interstitium. And by giving albumin, interstitial edema comes to the intravascular changes to intravascular volume. And that should be removed by a diuretic, that is furosemide. So this is how they tried the PAL approach. And in some, they have done only pilot study regarding this. It did show some negative cumulative fluid balance and it decreased the extravascular lung water index and also intra-abdominal pressure. So when we give diuretics for active fluid removal, if the diuresis is not able to achieve adequate diuresis to get a negative fluid balance, target certain negative fluid balance, or if any important side effects are occurring because of the diuretic, then it is called diuretic failure. This is occurring because all the patients have different GI absorption and they have poor kidney function or interactions with the other drugs. So when there is a diuretic failure, you consider the mechanical fluid removal. Mechanical fluid removal can either be slow continuous ultrafiltration, intermittent method of removal of ultrafiltrate, and continuous renal replacement therapy. So in all this, it is basically ultrafiltration we are looking at, that is hemofiltration we are looking at. So when we are doing a mechanical fluid removal, when the patient is on vasopressor support, the question is, already patient is on vasopressor support, can we actively still remove fluid? So most of the studies told yes, we can continue still at like a scuff which is done over 24 hours, like a very low ultrafiltrate removal per hour. So do accept an increase in the catecholamine support to facilitate the fluid removal. So when to stop the deresuscitation? So when the goals are met, which the goals have been discussed earlier in the ROSE concept, and whenever there are safety concerns that arise. So the goals can be fluid related to achieve a neutral balance, physiologic central venous pressure that is not very sensitive, and clinically the improved oxygenation, and maybe patient gets extubated because of the active deresuscitation. So in studies, when the rate of removal of plasma exceeds the refilling capacity, when we are doing a scuff or RRT, CRRT, if the refilling capacity is less compared to the rate of fluid removal, there's a compensatory fluid movement from the extravascular compartments to from the extravascular compartments, then it leads to hypotension. So that is, a patient can go into a hypovolemia status, which is not good. So fluid refill rate is normally 2 to 6 ml per kg to the intravascular compartment. But it may exceed up to 10 ml per kg per hour at high, if you remove high rates of ultrafiltration. So there was two recent studies that were published in this aspect, that is deresuscitation, RADAR-2 trial and classic trial. So RADAR-2 trial said feasibility of conservative fluid administration and deresuscitation compared with usual care in critical illness. So the role of active deresuscitation after resuscitation 2 is the study they have done. And they said that a strategy of conservative fluid administration and active deresuscitation is feasible. And whenever it is feasible, it reduces the fluid balance compared with usual care and may cause benefit or harm. So there are wide variations in the clinical practice. Large, adequately powered trials should come. Further studies should be done in this aspect. So there's another trial, that is classic trial, came in 2022. Restriction of intravenous fluid in ICU patients with septic shock. So again, it is difficult to get any intervention to show mortality benefit because a lot of other contributing factors are also there. This study also said that there is did not result, the intravenous fluid restriction showed any benefit in terms of mortality. Did not result in decreased deaths as compared to the standard intravenous fluid therapy. So now that we have seen how to do it and when to stop it, what is next? So we need more clarity in this aspect. We need more targets, more clinically available tools to assess the accurate markers of intravascular volume status, and also tools to predict the consequences of fluid removal, and at what are the optimal rates of fluid removal, and whether we can give something like albumin, adjunctive therapies like albumin, and vasopressor, whether a vasopressor is to be started to support the fluid removal or not. So this more clarity should be given in these aspects in the deresuscitation area. So my take-home message is one of the most common interventions in critically ill patients is assessment of fluid status and giving a fluid administration or removal. So both the intervention, giving and taking out, have potential for harm and benefit. So they should be regarded as drugs always. Fluids are drugs. So, and also always keep the points that fluid stewardship is telling, 4 points. So while stewardship and deresuscitation are important, also we have to avoid the going back to the pendulum swinging back to the hypovolemic patients, because if we use again inappropriately use high dose of diuretic and achieve a further significant negative balance, they can again become hypovolemia and start developing hypotension. So deresuscitation should not be fast, too aggressive, or too long. So when to stop, we should always know when to start, when to stop. How we are looking at fluid resuscitation, when to start, when to stop. The same way, I think we should consider deresuscitation also as an important parameter. Now, fluids are good, water is good, but water is also bad. So use it with utmost care, and whenever possible, do deresuscitate. Thank you. Thank you, Ghanshyam sir.
Thank you, Lavanya. Srinivas.
Yeah, I think we have reviewed fluid balance and fluid, what about IV fluids, and uh, we have about what IV fluids, how much fluids, what are the parameters, and now today we have actually reviewed the detrimental effects of fluid, positive fluid balance, and how you can diagnose somebody with a positive fluid balance and how you attempt to bring them back to a fluid homeostasis, and the importance of fluid stewardship, uh, as Lavanya said. But remember, I think we should remember one thing. While this fluid resuscitation, positive fluid balance, and the detrimental effects of cumulative positive fluid balance have got so much importance in the last 10 years or so, there should not be over enthusiasm in this, in the sense that you think about fluid resuscitation, fluid deresuscitation, or fluid overload after you have given the basic minimum required fluid resuscitation to a patient. Like if the surviving sepsis campaign says 30 mils per kilogram of ideal body weight, at least try to give that in the context of the patient hemodynamics, cardiovascular status, and lung status, and then think about de-resuscitation. I mean, we should not think about de-resuscitation even before we start resuscitation. It's good to think about de-resuscitation while we are optimizing the patient, may not or not even go into the phase of stabilization. But we cannot think about de-resuscitation when before we even begin resuscitation. That will result in under-resuscitation of patients. That's an important aspect. Now, every new tool, every new method has its proponents, opponents, and it looks very good to look at the VEXUS score and then put a number and say because my VEXUS score is 3 or 2, I'm going to put my patient on stuff for CRRT or whatever. That looks good, but what we need to understand is the intrinsic policy of the VEXUS protocol, in the sense that the VEXUS protocol begins with the assumption that the IVC diameter should be 20 millimeters or 2 centimeters for you to start the assessment of the VEXUS protocol. Now, when a patient has a fluid overload, when the patient has a global interstitial perfusion syndrome and an intra-abdominal hypertension, the IVC will be compressed. When the IVC is compressed, you will get an IVC diameter of less than 2 centimeters. Does that mean you don't assess this patient for fluid overload? You don't go ahead with the VEXUS protocol? That is the major roadblock or stumbling block of the VEXUS protocol. I mean, it is a vicious cycle. So when there is a patient who has a intra-abdominal hypertension, abdominal compartment syndrome, you do a VEXUS, start your VEXUS, you put the probe at the midline, and then you find that the IVC is less than 2. You will say this patient does not require a VEXUS screening, so you go ahead and give more fluids to the patient. And end of the day, you will end up perpetrating the same cycle again and again. So, if you are a believer and you are enamored by this VEXUS protocol, do for all the veins at the same time, even if the IVC is less than 2 centimeters. That's when you can pick up some of those abnormalities. The only thing which VEXUS protocol can tell us, if you are actually applying it and your IVC is actually more than 2 centimeters and you're able to get the hepatic, portal, and renal vein Doppler, the outcomes of patients are also proportionately bad. If the patient only has a hepatic vein abnormality, whereas the portal and the renal veins are normal or lower scores on the VEXUS protocol, these patients can get off with just diuretic-based offloading. Whereas those patients who have both the hepatic and the portal vein congested, but the renal vein is normal, these patients usually end up on a short-term renal replacement therapy. Whereas those patients who have the renal vein abnormality also have a 10 to 15% chance of developing ATN. because of renal hypoperfusion, not by hypovolemia, but because of renal venous hypertension and the consequent glomerular vasoconstriction. So this, if you are able to actually find somebody who has an IBC of more than 2 and you are able to apply all the 3 levels of the VEXUS score, you may be able to triage and prognosticate the patient and say your score is high on the renal score, so your prognosis is bad. So that's where the VEXUS score comes in. This is what I have to add, Ghanshyam.
Uh, just want to add one couple of points. One, see, we all talk about de-resuscitation, uh, and we have all identified or kind of recognized the fact that fluids are, especially when given in inappropriate amounts, are bad. And we also have kind of gone through the presentation where we have have some issues with respect to identifying the stage at which probably you'll need de-resuscitation or the technique or the quantity. Now, I think one of the best ways to look at preventing ourselves to be in that situation is to be very, very judicious when you're starting your fluids. So once you start being judicious about the every drop of fluid that you give, probably you will be in a situation where you may not need the de-resuscitation, or you may not be in a position where you'll be finding it difficult to find the answers. So keep a very, very close watch on the type of fluids you give, when do you give, what is the indication, and if you are giving the fluid for a specific reason, please follow up and see whether the reason for which you have given the fluid has that reason been addressed or not. So until unless you have a target and until unless you have achieved your target, don't give fluids without having these two things in mind. Thank you.
Sir, as for using albumin, I had a doubt, sir.
I'm not sure. And see, we all classically believe that you give albumin, the fluid from the interstitial space will drag out into the intravascular compartment, and then you give a diuretic. The diuretic is going to just drag the fluid out of the intravascular space. I really don't think that's as simple as that in critically ill patients. It's much more than that. So I don't think the dynamics and the kinetics are that simple. The albumin has multiple physiological effects. So maybe some of the benefits that we see with albumin may not be just related to the fluid balance or dragging out of the fluid. There could be multiple other reasons why the albumin could be beneficial. So it's very, very difficult to say that you give albumin and the fluid is just going to come out.
Okay, sir. Thank you, sir.
So thank you very much for joining us today. We will come back again with a new topic next week. We'll let you know what topic and the speaker are to be short in a couple of days. Those of you who have any queries or comments on this topic, may please post those queries on the groups from which you got this link, and we will try to answer them. Till then, thank you very much.
Thank you, sir.